Hello everyone, my name is Dr. Greg Chown. I'm a clinical associate professor in the health sciences. I'm also an occupational therapist, and I specialize in hand and upper extremity injuries, orthopedic injuries, and also burn injuries. I have a strong passion for jiu-jitsu and grappling, and I like to marry the two together, or my two passions together, which is anatomy and jiu-jitsu, and try to understand and learn about different anatomy and different injuries that may occur when we're rolling. And the reason for doing this is really for prevention, meaning injury prevention, and also sustainability. So as we get older, we can continue rolling in this amazing sport. So today I want to talk about armbar injuries. And there is one study out there that looks at armbar injuries. And this is a 2017 study by Almeida et al. And they looked at different types of armbar injuries, or I should say what the different types of injuries were from arm bars. And they looked at 5 high-level jiu-jitsu fighters that were injured during an actual tournament. Although the sample size is small, I think it gives us a good insight or starting point into what those injuries are. And I'm going to share what those injuries are with you in a second. But before we get to that, I think we should orientate ourselves to some anatomy here and then go into the results so we can understand what those results are from an anatomy point of view. So let's look at our model arm here and go over some basic anatomy here. So this top bone, which would be the bone right here on me, is the humerus bone. And let's look at some sort of locations here. So the top end is called the proximal end, and the far end is called the distal end. This will be important in a second because it's going to tell us where these injuries are occurring on those jiu-jitsu fighters that we're studying. This bone right here that kind of rotates around is called the radius bone, and then this bone on this side here is called the ulna bone. So on me, this side is my radius, this bone right here that I'm palpating or pushing on. Okay, so on the thumb side, this is the radius. It also can be referred to as the radial side of the arm. And then this bone right here is called the ulna bone. And so this is also referred to as the ulnar side of the arm. Now with our arm, we can turn it back and forth or up and down. When we turn it down, this is called pronation. When we turn it up towards the sky, this is called supination. When we do an arm bar and execute an arm bar, we always do it with our thumbs up, right? So it's kind of in a neutral position. If we go to our model arm here, what I want you to notice, there's this sort of funny structure right here on the proximal end of the radius, and it rotates around the ulna. Okay, so this is called the radial head. It has this sort of disc shape here at the proximal end, and it rotates around. The ulna does not rotate. And if you notice, we have sort of this kind of divot or groove in the distal end of the humerus, and this is called the olecranon fossa. And this portion, the proximal portion of the ulna is called the olecranon. And it's kind of like has this hinge joint, and it sort of locks in there, right? And this is going to be important in a second when it comes to armbar injuries. Okay, so some really basic anatomy there. Oh, the other one thing I just want to mention, the inside of the elbow is called the medial side. The outside of the elbow right here is called the lateral side. So on me, if we do anatomical plane, meaning standing like this is medial side, this is ulnar side. Okay, so medial side. Medial side is going to be super important for us in terms of armbar injuries. Okay, so on my model arm here, this is going to be the medial side of the elbow, and this is what's going to get injured or high susceptibility to injuries. All right. So in terms of results, we know that all 5 fighters were injured. They did, right after the injury, they had an orthopedic physical exam. What they found on the physical exam, all fighters were very tender on the medial or inside of the elbow. They were tender on the olecranon, which is kind of the backside of the elbow. So they had pain inside here. They also had some pain sort of on the bottom side, which is the olecranon. However, they did not have any instability in the elbow. So they'll do special tests or maneuvers to see if that elbow is unstable. If it's unstable, this tells you that there's some type of ligament structure that's been injured or ruptured, but they didn't find that, okay? They went and did an x-ray as well. X-rays all turned out to be negative. They didn't really find anything significant. When they did the x-ray, they did anterior and posterior views. So an anterior posterior view means that they're shooting the x-ray from sort of a back front side, okay? So this is the anterior side of my humerus, and this is the posterior. Posterior is the back side. So they do a view this way, and then they did a lateral view. Lateral view is on the sideways type of view. And why do they do x-rays from different views? Because sometimes on one angle you will not see the x-ray, the injury. When you move to a different angle, then all of a sudden you see the injury. So that's why they do that. So x-rays didn't really find a whole lot. However, they did do an MRI. Why would they do an MRI over an x-ray? MRI will pick up on soft tissue type of injuries, tendon injuries, ligament injuries, etc. And so they did that. Now, when they did the MRI, then they found the actual injuries. And so I'm going to go over those 3 injuries with you. The first injury was that in 100% of the cases, so all 5 fighters, the ulnar collateral ligament was ruptured. And this is super important. So the ulnar collateral ligament crosses across the elbow joint here, okay? So on the ulnar side, medial side, or inside of the elbow. And that is a very important ligament. It helps to stabilize that elbow. So if that ruptures, you lose elbow stability, meaning that your arm is going to kind of sway in the wind here. So if this pops or ruptures, I have nothing resisting or stopping it from going in that or a radial direction, right? I lose a lot of stability, especially during flexion and extension. Flexion, extension, right? I have nothing holding this. I'm going to kind of flop in the wind, and I have a very unstable elbow. So this is a very important structure. So it was 100% ruptured in every single case of all 5 fighters. The other thing that they noticed was total or partial rupture of the common flexor tendons, or the common flexor tendon, I should say. So I won't go too much into this right now because it gets very detailed, and we can save that for another time, but just sort of very basic overview here. So our flexor tendons are, if I make a fist here, these are my flexor tendons that are allowing me to do this. You can actually see the flexor muscles contracting right here, and I think of it like strings on a puppet, right? If I pull the strings, I'm going to move the limbs or the fingers or whatever on the puppet. So when I contract my muscles, I'm pulling my hand into a fist here, and it's going to contract. If you take your finger and you put it on the medial side of your epicondyle of your elbow, and you make a nice tight fist, you can actually feel the contraction here. So all these muscles attach right here at the medial epicondyle. What they're noticing during the armbar injuries is that they're getting total or partial rupture of this common flexor tendon. Okay, why is that? Because when I put my elbow into extension, usually past extension, right, hyperextension, I'm kind of pulling on that anchor. Remember, everything that attaches here at the medial epicondyle is an insertion point. Think about like an anchor, right? Or think about like rock climbing. I put an anchor in to hold the rope, and all of a sudden we're going to put tons of pressure on that. What's going to happen is something has to give, right? There's just too much pressure here. And that's what's happening in these armbar type of injuries. Now, the third and final injuries that they are noticed, that they observed on the MRI, is presence or areas of contusion and microfractures in the distal part of the humerus. Okay, so distal is going to be the bottom portion of the humerus, and also in the olecranon. Okay, so they're finding contusions and fractures in these areas, which would make sense. If someone's jamming my elbow into hyperextension, there's really nowhere for this to go, right? I have this sort of hinge joint, it's getting jammed in there. I'm going to get little microfractures in here. Okay, so that's what they're noticing. Okay, or repetitive type of injury here where it keeps jamming, and eventually we're going to get these little stress fractures in this area of the humerus and also the olecranon, which is part of the ulna. So those are the three injuries here. Now, all three of those injuries are going to require some type of intervention and treatment. The 100% rupture of the ulnar collateral ligament will need surgical intervention, and there'll be a lengthy rehab after that as well. The total or partial rupture of the common flexor tendon, same thing, probably surgical intervention depending on the severity of the partial rupture. The microfractures, more likely some rest and protection, icing it down, some pain meds, etc. And trying to avoid, in training, arm bars and things like that to let these microfractures to heal. But I think we can talk about that in a different video because those are just whole separate topics in themselves. All right. So those are the three injuries that were being observed on MRI studies of the 5 high-level jiu-jitsu fighters that were injured in tournaments. And I think it starts to give us an insight into what's happening from an anatomy point of view. So that being said, make sure you tap early so that you can roll another day. I'm all about sustainability and prevention of injuries. And so take care of yourselves, and I will see you next time.